Good evening. I can see that some of you are now joining the room. For those who don't know me, my name's Gemma Still and I'm the Chief Executive Officer at the Cancer Nurses Society of Australia. Welcome to tonight's webinar on cancer-related neuropathic pain. And we're delighted to be doing tonight's webinar in collaboration with the Australian Cancer Survivorship Centre, Cancer Council Victoria and the Clinical Oncology Society of Australia. I'd like to acknowledge and pay respects to the First Nations people as the traditional owners of the land. We pay our respects to the elders past, present and emerging, and acknowledge the different nations across Australia on which we all live and work. CNSA will continue to work together with Aboriginal and Torres Strait Island peoples to shape a health system which responds to the needs and aspirations of our community. And in the spirit of reconciliation, partnership and mutual respect, we also acknowledge any sorry business that may be affecting our communities as a whole. Now, tonight, we'd love to hear your questions and comments throughout the webinar, and we want to make it as interactive as possible. So please write any questions that you have in the Q&A function below, and we'll get to them as we can. Now, it's my great pleasure to introduce my esteemed colleague, Professor Jane Phillips, who is facilitating tonight's webinar. Thanks, Jane. If you'd like to come on now.
Thanks, Gemma, and to CNSA, COSA and the Australian Cancer Survivorship Centre and Cancer Council Victoria. It's great to be having this conversation this evening with regards to cancer-related neuropathic pain. And there's no doubt that this is a really significant symptom that's experienced by so many of our patients at different junctures of their cancer treatment, recovery and recurrence. So this webinar really recognises the expert skills that nurses, cancer nurses, allied health and other clinicians bring to addressing this problem, and the critical role that an interdisciplinary approach plays in terms of the management for cancer survivors. And I'm really delighted tonight to have so many of my expert colleagues who are so passionate about cancer related neuropathic pain to be speaking tonight. And so our speakers, our expert speakers aim to increase your knowledge and understanding about cancer-related neuropathic pain. And we're really hoping by the end of this session that you'll be able to have a better understanding of the pathophysiology of this distressing symptom, to be able to recognise the effects and impact that cancer-related neuropathic pain has on people living and surviving cancer, and also their family and carers. To also understand appropriate screening and assessment tools to enable you to more effectively identify this debilitating pain, and also to feel more confident to be able to implement best evidence-based interventions that will really support patients in their self-management. And equally as importantly, to understand where to refer and the resources that are available to support you in best practice of cancer-related neuropathic pain. So I'm just going to briefly introduce each of the speakers that we've got presenting on the panel tonight, and I'll ask them to turn their videos on and microphones as I introduce them. Delighted to have our consumer speaker, Karen Sanderson, who's, if you'd like to come online, my colleague, Associate Professor Melanie Lovell, a palliative care physician and somebody who led the development of the Cancer Council National Australian Cancer Pain Guidelines. Dr. Jessica Lee, who is another palliative care physician, but got enormous passion and expertise around neuropathic pain. My nursing colleague, nurse practitioner Michael Collins from Peter Mac, who is equally passionate about this type of pain, and our colleague Dr. Tim Hucker, who used to be at Peter Mac and is now in a private pain clinic. And Tim is also very passionate and has great expertise around interventional management of cancer-related neuropathic pain. So as Gemma mentioned at the outset, we'd really love to hear your questions and comments throughout this webinar. And we really want to make it as interactive as possible. I will endeavour to be a good chair and to be looking for your questions and try and weave them into the conversation. So I really encourage you to write your questions in the Q&A box as you think about them, and we'll do our best to try and answer them. So tonight's format is actually going to follow a case study, and we're going to follow a patient, and her name is Mrs. A, and she her details are just being popped up on the screen. But just to provide you with some context, she's 45 years old, she's married, she's got 2 children, a 12 and 15-year-old, and she's recently been diagnosed with multifocal breast cancer, for which she had a left mastectomy with sentinel lymph node biopsy 14 weeks ago for stage 2 triple negative breast cancer, and her ECOG is 1. And she's recently commenced on adjuvant chemotherapy. And she mentions to you when she comes in to have her chemo that she's got intermittent pain, she's got tingling in the chest wall, extending into her armpit and along her surgical scar, with occasional shooting pains, and it's intense itching, and she's actually got some associated numbness. She reports intermittent arm swelling, but she states it's nothing to be too bothered about. So we're just going to explore some of the signs and symptoms that Mrs. A has just disclosed to us. But before we do that, I really want to come and sort of hear from Karen, hear from somebody who's actually understands and has been living with the impacts of unrelieved cancer-related pain. And particularly of a neuropathic origin. And I'm wondering, Karen, if you can actually give us some insights about the things that you want us as clinicians to know about, but what it's actually like with living with this type of pain and how it impacts on your day-to-day life and well-being. So.
Thank you, Jane. As I was trying to work out what to say, I decided that it was probably best just to say as it is. The pain can be debilitating. It can start as a red hot poker-like pain to just a small electric shocks. It just depends on what is happening at the time. Doing buttons up is frustrating. You can't feel what you're hanging on to in the kitchen. I think I've probably dropped in total a setting of 4 cutlery and china that just for no reason is on the floor before I know where it is. I used to like a hot shower. Now I can't. The warmth of the water sends your hands and your feet in a tingling frenzy, and it takes a while for it to settle down. Cold is just as bad. So the frosty cold mornings, I'm no good. I can't walk. I can't hang on to anything. The kitchen, I think my husband's taken all the sharp knives away because he thinks I'm going to cut myself and not know about it. I used to love walking around in bare feet. It's not worth the lecture I get from my family, because if I don't know what I'm standing on, I don't know that the concrete's hot. I don't know there's stones under my feet. Shoes are an issue. If they're not comfortable, I need support, but they've got to be comfortable. And if they're too tight, when you take them off and you sit down, they throb. And it's just like a toothache. And it's constant. Nighttime especially, it takes a good 2 hours for the pain, the throbbing, the tingling to settle so you can get some sleep. And then for no reason, a couple of hours later, you're woken up by it. Climbing stairs, I don't know where my feet are. So the difficulties can be life-threatening, but they're more debilitating than anything.
So it sounds like it sounds like what you're describing is chemotherapy induced peripheral neuropathy, which has a very, very painful neuropathic component. Unfortunately, tonight we're not speaking about that because we think that's actually a whole topic in itself. But, and we promise we will do that next year. But I guess what I'm hearing from you is actually how debilitating and how this pain has actually impacted on so many different parts of your life, and how it sounds like, you know, it's very intermittent, but it never really goes away.
No, it doesn't.
Yeah. Is there anything else that you want to tell us about, you know, its impact on, you know, your ability to work, to enjoy social functions that you think we should know?
Well, it's got to the stage that I am retiring at the end of this year because I can't go through another winter with what I have. The cold weather, I can't do my job to my satisfaction because my feet and my hands won't allow me to. I think it's safer if I step back and let the younger clan make up. I have to be sensible. It's become to a point where I need time to look after myself, I think.
Thank you for sharing that story and being so honest and outlining some of the many challenges that you have living day to day with that persistent pain. And that is really helpful for us to think about it as we sort of focus on Mrs. A and start to think about what does her pain mean, and actually to really try and better understand the perspectives of those who've actually living with cancer-related neuropathic pain. So I'll come back to you a little bit later because I've got a few more questions.
By all means.
What was that? Yeah.
I said by all means.
Oh, good, good. So, but now, you know, we've sort of set the scene. So we've got the case, we've got all these experts online. So I'm really keen to come to you, Jessica, so to help us really understand about neuropathic pain and probably really to understand its underlying pathophysiology, and also to get a good overview of the different types of neuropathic pain. So already tonight we've heard two examples. You know, we've heard potentially about the neuropathic pain that Mrs. A's described, and now we've just heard from Karen about her chemotherapy-induced peripheral neuropathy and its associated pain. So it'd be great to hear from you to get an idea of, you know, just set the scene for us with regards to neuropathic pain. So over to you.
Thanks, Jane, and thanks, Karen, for sharing your story. I think it is really powerful to understand how much of an impact neuropathic cancer pain makes on people, and reminds us of how important it is to be able to address this. So what is neuropathic cancer pain? There's not a really widely accepted definition, but we do have a good definition for neuropathic pain, which is caused by a lesion or a disease of the somatosensory nervous system. And so that tells us where it comes from and what it affects. And we then need to figure out how this relates to patients with cancer and cancer survivors. And there are a number of ways in which cancer-related neuropathic pain can manifest. There is pain due to the treatment of cancer, and we've had post-operative pain, as Mrs. A has. As we think she may have, and we have a anti-cancer therapy-induced peripheral neuropathy, as Karen has so clearly described, as well as radiation-induced neuropathic pain. You can also get neuropathic pain related directly to the tumour mass and its impact on the nervous system, and pain which is in cancer patients but actually totally unrelated to their cancer. So what caused Mrs. A's neuropathic pain? During her surgery, tissue is damaged, which induces an injury response and changes the peripheral and central nerve pathways, which you can see in this slide. And so you can see here that normally sensory signals travel from the peripheral nociceptors along the peripheral nerves to the dorsal root ganglion and dorsal horn, up the spinothalamic tract to the brain, and then the brain sends back down modulatory signals to inhibit the pain response mediated by serotonin and noradrenaline. And these inhibitory neurons are stimulated by activity in other sensory fibers in the same segment. It also integrates, the brain also integrates pain sensation with past experience, cultural inputs, and meaning. So in Mrs. A, these peripheral nerves have been injured, which causes increased sodium channel expression, glutamate release, which drives pain signaling, and ectopic spontaneous excitability in the neighbouring sensory fibres. These trigger the sensation of pain, and altered gene expression in the dorsal horn and dorsal root ganglion increase the spontaneous impulse discharges, reducing the thresholds for firing, and increasing the response to peripheral stimuli. This causes central sensitization, which contributes to hyperalgesia and allodynia. And there's associated upregulation of calcium channels, which increase transmission of signals and responsiveness. Now, some of these changes improve when the wound heals, but some are irreversible, causing chronic pain. And you can see here that along this nerve pathway, there are many targets where we can potentially intervene to improve our management of cancer pain. So what might alert you to the fact that somebody might have neuropathic pain? So thinking about that mechanism that we've just seen, neuropathic pain might be signalled by symptoms which are suggestive of nerve involvement. So we heard Mrs. A had shooting and itching pain. You can also get pricking, tingling, pins and needles, electric shocks, jumping, bursting or stabbing sensations. And then because those neighbouring sensory nerves are affected, you can get changes in the skin and temperature, causing mottled or red skin or hot or burning sensation. You can get numbness, as Karen explained, which can be incredibly debilitating. And you can get what's called hyperalgesia or allodynia, which is where you have an increase in sensitivity so that a normal pain touch actually feels very painful. So, okay, I've jumped to the conclusion that Mrs. A has post-operative pain, but in fact, you do have to think about her differential diagnosis. There are different types of post-operative pain. You can get different nerve injuries in different places, neuromas, which are growths of nerve tissue. You can get phantom breast pain, and you can get other things such as musculoskeletal pain syndromes, frozen shoulder, or lymphedema. So you've got to actually think of all the different possibilities for her pain.
Thanks, Jessica. It was great to go back to pathophysiology and also to hear about your differential diagnosis and the many different potential underlying causes for her cancer-related pain. So I'm going to go to Melanie Lovell now. So Melanie, just sort of picking up on Jessica's differential diagnosis, which we've just heard, and her the potential underlying pathophysiology that may be contributing to her cancer-related neuropathic pain. Can you tell me, as a clinician, how are you actually going to confirm this differential diagnosis? And is there anything else you would want to do at this time to really confirm that she's got neuropathic pain and the type of neuropathic pain that Mrs. A has?
Thanks, Jessica, for going through that pathophysiology. Yeah, I'd want to be doing, in order to confirm the diagnosis, I'd want to be doing a full assessment. So when we're assessing someone for pain and what the potential cause is, we're really wanting to nail the cause of the pain and the mechanism. And really just to, summarize the points that I'm going to go through as I describe this process. Pain screening to understand the severity should occur at every clinical encounter, and often a numeric rating scale is most helpful. And we can see here the symptom assessment scale, where 0 is no pain and 10 is severe pain. It's also got the FACER scale and the words for people who find the numbers difficult. You do need to do a rigorous pain assessment, and I'll go through the elements of the pain assessment next in order to identify that it's neuropathic pain in cancer patients. And there are some tools that can help us, and I'm going to show you 3. And there's a really good concordance between the tools and a clinical diagnosis, and it does make it practical for identifying potential cases of neuropathic pain. On the assessment point of view, I'd just like to mention the National Cancer Pain Guideline, which has a very thorough section on assessment. And assessment is a talk in itself. I guess the key things to mention are we want to understand the pain experience, and sometimes we use the mnemonic PQRST for that, where P is the precipitating and relieving factors. Karen describes so beautifully how heat and cold triggered her pain. Q is the quality of the pain, and this is where we have the descriptors around, shooting, burning, tingling, and so on, but also quality of life. And again, Karen describes so clearly there the interference that the pain caused with so many aspects of her life, her ability to walk and work and her ability to sleep and so on. R is radiation, and we heard in Mrs. A's case about that radiation to her axilla. PQRS is S is for the site, and T is for the timing. But that's really just about the pain experience. There are lots of other elements of the pain assessment, and if we're going to get a good differential diagnosis, we're going to need to go through those. So in addition to the PQRST, you're wanting to think about the current and previous management of the pain, so what's working and what's not working. You want to think about other symptoms, and particularly psychosocial triggers. You want to understand how much distress the pain is causing, and whether there's any risk factors for medication misuse, and that's a important factor. We want to think about risk factors for poorly controlled pain, and neuropathic pain is one of those pains. And we also want to do a physical examination. So this is the first of the tools I'd like to show you. It's the DN4 questionnaire. And you can see that there's history and examination is very important in the full assessment. I guess the third element that's important, that's part of the assessment, is investigations, because we want to identify what's actually causing the pain. History, like Karen's, it's clear it's going to be related to medication. Similarly with Mrs. A, related to surgery. But it might be that there's a new cancer spot causing some of these symptoms, and we really need to be identifying something that's going to be causing either a peripheral or a central nerve injury. So the descriptors in this tool are burning, painful, cold, electric shocks, tingling, pins and needles, numbness and itching. And then on examination, there's is the pain located in an area where the physical examination reveals one or more of the following characteristics: hyposthesia to the touch, which is numbness, or hyposthesia to pinprick, or in the painful area, can the pain be caused or increased by brushing? And that's the sort of allodynia that Jessica mentioned. The next one I want to mention, I haven't shown the tool in full. Please go to the next slide, Liam, is the LANS. This is probably the most commonly used tool. I haven't shown it in full because it doesn't quite fit well on a slide, but the key questions here again are descriptors and clinical examination. So would you describe your pain as having strange, unpleasant sensations in the skin, pricking, tingling, pins and needles? Does the skin in the painful area look different, mottled, more red, pink? Is the skin in the affected area abnormally sensitive to touch? Does your pain come on suddenly in bursts for no apparent reasons when you're still? Do you feel that the skin temperature in the painful area has changed? And does stroking the affected skin with a piece of cotton wool produce an unpleasant, painful sensation? Does touching the affected area of skin with a sharp needle feel sharper or duller? And that's the hyperalgesia that Jessica also mentioned. And then the final tool, which is actually my favourite tool, is the pain detect questionnaire. It's too small for you to read on the screen there. But essentially, the scales at the top there are severity of pain now and on average and its worst. And you can see the diagrams with the red in them. That's the time course of the pain. Is it persistent pain with slight fluctuations? Is it persistent pain with pain attacks? Is it pain attacks only with no pain between them? Or is it pain attacks with pain between them? And then there's a body diagram where you can mark where the pain is, but also where the pain might radiate to. And then the second half includes the descriptors that we've already heard with the previous tools and in the descriptions of both Karen and Mrs. A. So thank you, Jane.
Thanks, Melanie. I could see why we could do a whole session on screening and assessment, but you've provided a really good overview and a great introduction to, a couple of tools that we can really use to sort of unpack the person's neuropathic cancer-related pain. So, Michael, I'm going to come to you because I know that this is your bread and butter as a nurse practitioner and a frontline worker, and really keen to hear from you what you see as the nurse's role in screening and assessing patients like Mrs. A for unrelieved pain. So, just picking up from Melanie's presentation. So how do you apply it in clinical practice?
So thank you, Jane, for the question, and thank you, Melanie, for outlining those really useful tools. And I would endorse everything that Melanie has said. I've been a registered nurse for 36 years and a nurse practitioner for 12. And there's been many positive developments down the years in identifying patients with pain and the work around asking patients about their pain at every clinical contact, asking them to use a validated assessment tool are all value aspects of this approach to pain management. But what I'd say is that pain is more than just the fifth vital sign. Pain can affect mood, it can affect function, it can affect sleep. It stops us from doing the activities we enjoy, our capacity to work, sometimes our financial independence and the relationships. So it's a really important subject. And I would endorse the multidimensional approach to pain assessment, not just the severity, which I think we sometimes use as our first port of call, but also the experience, what the patient experiences of the pain, the duration, the description, but also the impact of the pain. What's the most annoying feature of the pain on the patient? And it was interesting to listen to the consumer's experience about, just not being able to do buttons up and minor things like that, and how that can just be a reminder of the situation that they're faced. But I think there's more that can be done, and I'd prefer not to conceptualize what the nurse's role in pain management is, but I'd like to think about it as how can nurses help patients get the best possible care? So my approach is to try and focus on how can I help this patient at this time? And I think nurses are really great translators of the healthcare system. Every year when I go to CNSA, I'm blown away by a lot of the presentations that are made and all the great work and all the generosity people put into their work. And I think that the nurses act in translators in two ways. The first way we translate is often we explain medical care to patients and their families. But conversely, often patients will report important information to us, and then we feed it back to the medical team so that they can decide, that informs their decisions and how we proceed with care. So I think our role as translators is really useful. And there are some foundation clinical skills, communication skills that I think are really important in fostering this role. The first thing is that before any clinical contact, it's good to know a little bit about the patient. I've heard stories from some colleagues that say, oh, I've been dragged into a room and the patient's got my contact details and they've been told to ring me if the pain's not getting better. And that can be a really difficult situation. So it's really good if you've got the discipline to know something about the patient before you go and meet them. And then if it's not possible, maybe scheduling just a telephone call or a touch base after their clinic appointment so that you can gather that information, and even having a foundation assessment. If the patient's going to ring you up and ask for your advice, it's good for you to know where they were at the point of their initial assessment. I also think it really gives a real positive message to the patients that you're invested in their care and are capable of helping solving some of their problems.
Great. So really wanting to understand I can hear you really wanting to understand the patient experience, and thanks for drawing out around how we often use the numerical rating scale, and it's a really important, but it's actually a screening tool. It's actually part of the assessment, but there's much more to the assessment, which is really important. So now that we've established that the pain is cancer-related neuropathic pain, and we've screened, we've done a great assessment, and now we need to really think about the management. So I'm going to come back to Jessica, and then I'm going to come to you, Tim, in a moment, but we'll go to Jessica first. So, as I said, we've confirmed that Mrs. A has cancer-related neuropathic pain. So I'm actually really keen to hear from you, Jessica, about how you're going to think about managing her pain from a pharmacological perspective.
Thanks, Jane. And I think it's important to recognise that the pharmacological management is just one part of her holistic management, and it's taken in context of everything that Michael and Melanie have assessed about the patient, about the patient's pain and their patient and the patient. And taking all of that information will allow you and Mrs. A to make a shared management plan, which may or may not include pharmacological management. But if you did choose, if you did feel that pharmacological management was required at this stage, the principles that you need to think about are: what are the medications available? What evidence for efficacy do we have for those medications? What adverse effects do they have? And how does that impact on the comorbidities that Mrs. A has? What is the cost of the medicines? And come back, you've assessed her, but you need to come back and reassess her and reconsider whether your initial management plan was appropriate. So what would I do for her? Well, I think I'd probably choose one of 3 medications as a first-line medicine for her. The most evidence I think we have are for the oral anti-neuropathic agents pregabalin, amitriptyline, and duloxetine. There are other medications, and I can go through those. And there are other topical or non-tablet forms of medication which can be used. So first, thinking about the gabapentinoids, these are anti-seizure medicines originally used for patients with focal seizures, and there is pregabalin and gabapentin. Pregabalin is probably the only medicine other than amitriptyline which is on PBS for neuropathic pain, which is a factor for a lot of patients. And as with all of these medications, the evidence demonstrating efficacy in patients with neuropathic cancer pain is quite limited. We have evidence, we extrapolate from evidence in the neuropathic pain population, which suggests that pregabalin requires around 7.7 people to treat to have benefit in pain for those patients. And there are 2 trials, one by Caracini and one by Mishra, which do show that pregabalin can be effective for neuropathic cancer pain. The most common adverse effects are irritability, depression, balance issues, sleep issues, and arthralgia. So the other medicines that I would consider, amitriptyline is a tricyclic antidepressant. It has probably the lowest number needed to treat for all of the antidepressant agents of only 3.6, but also the most adverse effects. And it's perhaps the most difficult to use in my patient population, which is quite an elderly patient population with a lot of comorbidities. Its anticholinergic effects can increase the risk of delirium, dry mouth, and cardiac toxicity. Duloxetine is another good agent with evidence, very good evidence in the neuropathic pain population, and some evidence in the cancer related neuropathic pain, in particular in the chemotherapy-associated peripheral neuropathy population. And I think Tim is going to talk a little more about that, as well as some other possibilities you can use, which include topical agents such as lidocaine 5% and capsaicin 8% or cream. I will note that there are medicines without strong evidence in neuropathic cancer pain, including paracetamol, non-steroidals, cannabis, and lidocaine or ketamine infusion, which can be considered in certain circumstances, but acknowledging that there is evidence that they may not work. And similarly, for opioids, they're very complex, and we will come back to them.
Yeah, so just brief, thanks, Jessica. Lots to think about there. Just got two questions. So at this stage, you're not thinking about opioids for Mrs. A?
No, I think that she does not have active disease. She has pain which is probably going to be with her for a long time, which is neuropathic in nature, and it sounds like it's relatively mild. So no, I would not choose an opioid for her. Perhaps Tim would like to comment, but I would say that there are some patients for whom an opioid may be appropriate, and it's important to remember that a lot of patients that you will see with neuropathic cancer pain actually have a mixed pain, different to Mrs. A.
Okay, that is great. Sorry to put you on the spot, but just keen to know. So come to you, that's probably a really nice segue to you, Tim, and as the pain specialist, you're the last person we've come to, which is not really good modelling, but you've just heard about Mrs. A, and you've heard what each one of the clinicians have thought about her pain and what they might do. So what are you thinking about her neuropathic pain as a pain specialist?
Thanks, Jane, and thanks, Jessica. It's interesting that we're moving to anti-neuropathics that we've always sort of traditionally called the sort of atypicals, like duloxetine. And I'm a big fan of duloxetine. Looking at the sort of the whole neuropathic pain literature, the duloxetine's actually got the best number needed to treat for a neuropathic pain condition. It's not a cancer one, sadly, and that's diabetic peripheral neuropathy, and also post-herpetic neuralgia. And I think it was Jessica saying we're extrapolating from the general neuropathic pain population into cancer, and that's limited, but of some use for when you're on the front line and clinically struggling with a post-mastectomy patient, for instance. There are quite a lot of similarities in some of the pain pictures that people in this situation present with to both of those conditions. The diabetic peripheral neuropathies have a lot in common with some of the toxic neuropathies of chemoneuropathies, and the mechanism is the same in some of them. So we'll talk a bit later about interventions, but one of the things that we see quite often is that people are maybe referred for an intervention or considered refractory and haven't tried something like duloxetine. Where I think it's most beneficial clinically are the really sort of positive feature neuropathic pain that Melanie was talking about, that sort of the burning, electric shock, extreme hyperesthesia, allodynia, sensitivity to the bra, light touch, those sort of really positive features rather than that sort of numbness, dull, sort of really sort of horrible gripping nerve pain that people describe. I think duloxetine is particularly good in that situation because that sort of post-mastectomy pain in some ways reflects a post-hepatic neuralgia, very superficial, allodynic, hyperesthetic. I would put a mention in for lignocaine patches, and Jessica's right to say they're expensive. As a practical tip, get hold of your lignocaine rep and say, we want free samples, otherwise we're not going to use them. Because what you then can do is give someone a free trial, and then rather than having to go out and buy them, they get at least a week's free trial out of it. And if it's good, they then can make a value judgment as to whether they want to continue prescribing it. The 5% patches, I'm sure everyone knows, sort of big hand kind of size. You can actually also cut them to shape really effectively as well. So if someone's got that long sort of post-mastectomy scar, long sort of dermatomal, long thin dermatomal neuropathic pain, then you can cut a couple of strips off, and then you'll get 2 or 3 uses out of the same patch. So what was 5 patches and far too expensive now becomes 15 uses if you're getting 3 uses out of the same patch. By uses, I mean there's still 12 hours on, 12 hours off, but you cut the patch into 3. And the final quick thing is if you're struggling with NDEP, amitriptyline, nortriptyline is NDEP's cleaner younger cousin, and in fact, amitriptyline is converted to nortriptyline partly in the body. So if you have someone who's going well on NDEP but troubled by the side effects, you can directly swap to nortriptyline at the same level, and you should get similar efficacy and less side effect. Doesn't quite work like that, sadly, but it's can be a neat trick for some people. Thank you, Jane.
Thanks, Tim. I guess you realise there's 115 people online. I'm sure they're all going to phone the lignocaine rep.
Do. They should stop charging so much for their patches.
Yeah. Thank you for that overview. We do have a question, so I'm going to actually a couple of questions. So I think one of them would be great for you, Tim, or Melanie, or Jessica, whoever would like to answer it. And how many clients use non-prescribed cannabis oil for nerve pain, and how effective is it? Does anyone want to take? You mentioned cannabis, Jessica, so that might go to you, unless Tim, you want to comment.
After you, Jessica.
Okay, I think it depends on your patient population. I work in an area full of elderly Greek and Italians, so the number of non-prescribed, the amount of non-prescribed cannabis use is relatively low compared to some of my colleagues. However, we do get frequent requests. The current evidence for cannabis in neuropathic cancer pain is poor. There's not enough evidence to recommend it as a first or second line agent. However, sometimes when you have exhausted all other options in the context of an informed consent discussion, it can be worth a trial with an individual patient, with coming back to that constant assessment and reassessment. So that's prescribed cannabis. I can't tell you, I don't tend to recommend non-prescribed cannabis.
Yeah, thank you. That's a good product warning. Tim, I'll come to you with this question, and then we'll move on with the discussion about Mrs. A. One of the members of the audience would like to know, what about coexisting central sensitization with chronic cancer pain, cancer-related neuropathic pain?
Yeah, it's hard, isn't it? I mean, the more refractory cancer neuropathic pains we saw ended up on sort of weird and wonderful regimes of at least 2 anti-neuropathics. And some of them we were moving more towards the infusional treatments or even interventions because they'd become so refractory. It's it's a particular problem in the post-surgical population. Those, the biggest risk factors for persistent post-surgical neuropathic pain are pre-existing poorly controlled pain. So we're, someone who has to go back for surgery after surgery, you're just adding fuel to the fire in many ways with the pain, as well as anxiety and depression. So I think it's difficult to give a discrete answer to that, because it's very unique from person to person. What I think it does definitely require is the whole gamut of the multidisciplinary team. The psychologist to assess coping strategies and helping someone almost dialing down that existing central sensitization so we can deal with a new problem. The physio, can they do any sort of desensitization for the newer thing? Linking in with the whole team and recognizing that we have to treat this central sensitization part in the sort of chronic pain sphere, whilst keeping the cancer-related neuropathic pain in pal care and pain, with all hats on. And yeah, I can't give you a discrete answer.
Thank you, but that's
sorry.
That
was Siri.
All right. Sorry, was Siri. That's great. I just want to go to Melanie for a moment, because we've heard about the pharmacological management, and there are a few questions coming through from the floor around about self-management and non-pharmacological management. But I do want to get you to speak about, what's the type of advice you would be providing to Mrs. A about how to manage her neuropathic pain at home?
Thanks so much, Jane. Yeah, thanks for the questions too about self-management and supportive management. I think the nice thing about these non-pharmacological strategies, including education, is that they can go alongside pharmacological strategies. And I agree, often in a pain like this, depending on what impact it's having on Mrs. A, you could consider these first before trying something pharmacological if it's a very minor issue. I mean, one of the things that I was a little concerned about in the way she was describing it was, when she said it was not much of a issue. We know that there's a number of barriers to management of pain, and it may be that she was wanting not to distract the doctor from treating her cancer, or some other reason. So I think when you look at what's most effective in education, and I know nurses in particular spend a lot of time, very important conversations around education around pain and pain management. Things that tend to be most effective are those that enable people to be involved in their own pain management, such as pain management plans, goal setting, and pain diaries. It is important to discuss whether people may have barriers to pain management. Common ones are fear of addiction or stigma, fear of tolerance. I don't want to use opioids if they were to be appropriate. And so good to just talk through some of the barriers, and some of them can be cultural. And I just note here this Understanding Cancer Pain book, which has quite a lot of information about that. It's a book that's now, I think, in its 6th edition, and was shown in association with a DVD to be effective in a randomised controlled trial. Evidence-based non-pharmacological strategies can be employed by patients at their convenience, and they include, the evidence-based ones include heat, exercise. I think someone asked a question about massage, meditation, and there's a list of them on the Cancer Pain Guideline. Next slide, please, Liam. And now I just want to go through this pain management plan. It's something that you can sit down with your patient and do together to negotiate actually what's going to work. The worst thing is to have something prescribed that they're not going to take. So if the regular pain management is duloxetine, for example, what would they take if they have extra pain between times? If it's an opioid, how are you going to prevent any adverse effects? and including on it the things that are helpful. And you can see there we've mentioned heat massage and distraction. Distraction is incredibly powerful, including watching television, that sort of thing, but also things like virtual reality, where we've got some nice early evidence on. The idea in the top right there is around an acceptable pain score, because some people aren't aiming for a 0. A lot of people have had pain for some time and they're aiming for another score. So working out, what their aim is, when to seek help, who to contact, and who was it discussed with. I wanted to introduce to you a couple of self-management resources that are freely available. There's a QR code there for the Cancer Pain app. It's a companion to the Cancer Pain book there. These are resources for patients to explain to them about cancer pain. And you can see there on the left of the screen, there's mind exercises, and then there's body exercises. There's about 15 different mind exercises: belly breathing, pursed lip breathing, progressive muscle relaxation, imagery. And in terms of the physical exercises, there's some stretching, resistance exercises, and Tai Chi. All of them are evidence-based and have been put conveniently together into a free app. Importantly, any of these self-management strategies are most effective if the health professional endorses them and says, yes, I really recommend this to you. And there's some beautiful feedback about the reduction in analgesia that people need when they use these resources. Thanks, Jane.
I love those resources, and I've just noticed Liam's will put a link and in the resource list. So thank you for sharing that. One of the participants in the audience have actually asked about ice. So I noticed, Melanie, you spoke a lot about heat. Is there any evidence about the use of ice packs for neuropathic pain? And is that something?
Yes, there is, and everybody's different. So some people, as Karen described, would find that intolerable, but for many people, they can find it very cooling and pleasant.
Great, thank you. So, Michael, really keen to know about what you're going to suggest to Mrs. A from a non-pharmacological perspective. So, in your nursing role, what are the type of things that you're going to be suggesting to her?
Okay, I think it's really useful to get a baseline of what the main issues are. So, and while we talk about pain, there are also associated issues. Has it affected sleep? Has it affected mood? What's the impact on the life? And then if there are issues like that, how can we what are the additional supports that can be employed to address these things? So if there's something that is restricting functional, say, what can a physiotherapist do? So those are the sort of things that you would address with a physio. Psychology, we've talked about desensitization. What's the effect on mood? Are there parallel symptoms that are operating side by side? Often symptoms come in clusters. So, for example, somebody who's had pain for a long time, what else has it caused, and is it going to improve with just the change to the pain management plan, or are there other interventions that need to work in parallel? So having a broad-based assessment of impact is really useful, and thinking about those other services is good. The other things I would also say is that often when patients come to clinic, it's a very overwhelming experience for them. They're presented with massive amounts of information, often in a very technical way, and that even if you ask them, is everything okay? Did you understand everything? They might say yes, but often just a touch base in a couple of days just to make sure that it's resonated with them and they don't have any additional questions. That's also a really useful strategy. And also doing the screening outside of the main consult when they might be more able to describe things might also be a useful tool.
Great, thank you. There's a couple of questions here, and I'll sort of open it to the floor with regards to, because we haven't really spoken, we've briefly mentioned about the role of physiotherapy, but do we have any comments regarding allied health, exercise, movement, complementary treatments, massage therapy for neuropathy, exercise and acupuncture? So So, Melanie,
I'll
you'd
take that
like to
one,
begin?
Jane.
Yeah, that'd be
Yes,
lovely.
yeah, absolutely. So all those things there's evidence for. Actually, the acupuncture evidence took a while to come in, but it has come in. And a physiotherapist would often lead the exercise. I showed them on the app, but physiotherapy-led exercise sessions are incredibly helpful and important. All that relaxation can be done by other or led by other allied health team members. So, and in fact, the development of the app was in response to the fact that often allied health is pin on the ground, and so for an allied health professional to give the app to someone for follow-up before the next appointment, that sort of thing. So yes, thanks for raising that question.
Yeah, thank you. And great that we've now got access to the app. So we're going to sort of, Karen, just before we move on, I'll just come to you. Do you have anything, how are you feeling about the way the team are managing Mrs. A's cancer neuropathic pain? You got any suggestions for them from a consumer perspective? Do they get the tick or?
Yes, they do. I have tried acupuncture. It worked quite well on my fingers, but not so much on my feet.
Yep.
I have used breathing techniques when the pain is at the point where you're almost in tears. And I have tried some pharmacological things as well.
Okay.
It's hard to describe how you can treat it because everyone is individual.
Yeah.
And the severity is different in everybody. So it's a matter of digging deep enough and getting the information from the patient as to exactly how bad it is.
Yeah, thank you for that reminder and the individual nature and reminding us really what the definition of pain is, you know, according to what the patient says it is. So we're going to, I might just get you to mute for a moment, but we're going to move on to the second part of the study. So, you know, despite the team doing their very best, you know, several years later, Mrs. A represents having developed recurrent disease, and she's now got multiple bone secondaries, particularly in her axial skeleton, and she's got an upper left lung lesion. And more recently, she's developed pain radiating into her left shoulder, and it's intermittent shooting pain in her right leg, radiating down her buttock and into her calf. And she's still bothered by the post-mastectomy pain, as we've heard that can often be quite chronic. And she's distressed to be now experiencing these new pains, and she's actually been referred to Tim. So Tim, I'm really keen to hear from you about what you're thinking about Mrs. A's pain and how might an interventional pain service be able to assist her.
Thanks, Jane. I thought I'd expand slightly on what you're saying there, Jane, and just go through, rather than going through the nuances of the individual sort of injections in each situation, but more a sort of where interventional options fit in cancer pain as a whole, and some of the broad considerations on interventions that we think about as pain specialists. With this first, I'd excuse the awful slide, but the huge block of text on the left is just the recommendations from the NCCN about interventional strategies in cancer pain. Probably need to put a few less words on a slide, but I just really want to show there's an international kind of basis for doing interventions. There's the advice you can see in the bottom right-hand corner about invasive management of refractory pain from European Society, and people have sort of talked about different models, but you know, where exactly does it fit in? Is it the fourth rung of the ladder, or all sorts of other sort of different models have been strategized. We'll all be familiar with the amazing piece of work from Melanie and Jane and others in this room. Where I think it fits is it fits really well in the Australian model, and that is it should be considered for people with non-responsive severe pain, and it doesn't specify where in the journey that is. it can change from an intervention for a dressing change, intervention for a surgery, an intervention for end of life, an intervention in the cancer survivor. I think that's probably the most crucial thing that I think about in terms of an intervention. So when it comes actually to referral for an intervention, there are a couple of questions I think we really have to answer before we even sort of consider which one we're heading to. Have we done everything simple first? And that example we had earlier of, a lot of people haven't tried some of the obvious analgesics. A lot of people haven't engaged with a psychologist yet, are extraordinarily anxious. Trying to do an intervention on someone, bristling with anxiety is really should not be undertaken. What are we trying to achieve? That's, I think, is really important. Are we trying to just provide analgesia, which is fine, or are we trying to provide analgesia with the goal of getting through a treatment? Are we trying to provide analgesia for functional gains? So are we sort of linking in with the right people at the right time? What I'm trying to say, I guess, is that the intervention on its own is only so useful. It's got to be tied in nicely in the whole journey. That takes a while to sort of, for us as pain specialists, get our head around. We like to do things and then assume that something good will come as a result. But actually, you've got to think of step 2 and step 3 past the intervention. Next slide, please. So what interventions are we actually going to do? And we get a lot of referrals for nerve blocks. And I just want to sort of run you through the actual process of an intervention. So a nerve block does nothing more than tell you which nerve is carrying a signal of pain. So it's a diagnostic tool rather than a treatment procedure. And there are some provisos to that. We can get a slight degree of longevity by doing a nerve catheter technique. So, people with pathological fractures in hospital and it's taking time to get them to theatre, or, for dressing changes. For some of the ganglion blocks, so collection of nerves, we can get some longer term benefit. But you're looking at sort of days, weeks, and in the case of ganglion blocks, months at most. So it's worth considering that if you're referring for an intervention, you're not referring for a nerve block, you're probably referring for a nerve block and then something that provides longevity. Look, the nerve block will really only last as long as a local anesthetic. So there are some longer acting versions of what the dentist uses, but 24 hours is a good result for a nerve block. So how are we going to provide longevity? So there are 2 means of doing that. We've identified that a significant amount of pain is transmitted by this nerve or group of nerves. So we can either destroy that nerve on purpose, and the main example that you'll probably all be familiar with in practice is the celiac plexus block. So someone with pancreatic cancer, we can ablate those nerves with phenol or a strong alcohol. In some cases, you can ablate nerves with electricity. So again, someone with a limited prognosis, and we can accept that loss of other functions of that nerve will be okay. More and more what we're doing is looking at neuromodulatory procedures. So what we're trying to do in that situation is to try and get to a nerve, not destroy it, but say desensitize, calm down, stop sending so many pain signals. And that works more biochemically by stopping receptors migrating to the site, stopping the ability of receptor to send an action potential. It's a sort of calming and re-education process rather than a damaging process. And the means to do that are divided into a number of things. They're very simple: needle, day case intervention, things that you'll be familiar with. So pulse radio frequency. So going back to Our Lady, she had some nerve pain going down the leg. We can do a very simple day case application of an electric current to that nerve, and that will, in a good outcome, provide about 6 months, 50% pain relief. Then there's the more invasive and implanted procedures. Intrathecal pump is pretty much used in the shorter prognosis or short to medium term prognosis, where most of the evidence is abroad, short prognosis in Australia. And the bone metastasis situation, someone with uncontrolled pain, particularly troubled by worsening side effects, an intrathecal pump where we're applying opioids to the site of nerve signaling in the spinal cord and therefore reducing the dose and providing better analgesia is the goal of that. And finally, spinal cord stimulation, which is an implanted device, much like a pacemaker for the spine, that's trying to reduce sensitivity in nerve pain. So, for instance, if this lady had a prolonged nerve pain going down the leg, that is when you could implant a spinal cord stimulator. The expanding out of her, this is quite a good resource from the American Society of Pain and Neuroscience, and just, I think, sums up where neuropathic pain as a whole, so not in the cancer pain population, and how that's kind of treated that most of us as pain specialists would follow. The importance being the white bar that follows it the whole way through. It's got to be multidisciplinary care. But interventions come low down in our list, and then the more invasive interventions come even further. There's a place for them. It's a refined place. It's a limited place. But there are some real sort of specifics and some real benefits you can achieve as long as you've thought through the process of where to next and what are we trying to achieve. Just quickly, as you can see, we're talking about the atypical antineuropathics. So the SNRIs like Cymbalta are now kind of first line, as Jessica was rightly saying. Thank you very much, Jane.
Great, thank you. That's a great slide with that schematic overview about thinking about approaching it, and also really liked your reminder about the multidisciplinary team approach, which is really so critical. So that's probably a really nice segue, because we've had a good overview of thinking about various pharmacological and non-pharmacological approaches that may be actually helpful. And Tim and Jessica have both touched on the role of opioids, but I really in relationship to managing neuropathic pain. But I'd like to come to Melanie now, because we're in a situation where things have changed for Mrs. A, and I'm really quite keen to get you to walk us through whether opiates ought to be considered in this situation and how you would go about appraising that. So,
yeah, thanks so much, Jane. I think there is a distinction to be made between whether or not she's got active cancer and whether she's got recurrent disease, and she's clearly got recurrent disease now. In someone who is a cancer survivor with ongoing neuropathic pain, the role of opioids is limited. Similar to other types of chronic pain, there'd be very selected patients who you might try them for. In contrast, now that she's got recurrent disease, the priority is to get the pain under control while she's having, treatment for the painful sites. It may be that, so diagnostically, I'm thinking that she's got, some a viral metastasis that's causing some nerve impingement that's radiating down her leg. The lung mass may be impinging her brachial plexus, which is what's causing the shoulder pain. So she's got two new neuropathic pains. And the chance of getting on top of those with neuropathic agents alone is limited. And so there's definitely a role for opioids here. And I would be starting with something simple. Again, the Cancer Pain Guideline gives really good guidelines around, what to start and how. But for someone like Mrs. A, around sort of 5 milligrams of morphine every 4 hours. And you can also start with a long-acting analgesia, and depending on how much breakthrough analgesia is required, that's how you titrate. You can gradually increase the amount. In considering that, you need to have a good discussion about the adverse effects. You need to work together about, again, whether there's any barriers for Mrs. A using opioids or concerns. Are there any risk factors? For instance, in her house, is there someone who is an opioid misuser? There's a conversation around that. And you do need to prescribe some adverse event prevention, laxatives, anti-emetics, and so on, and follow up. So you would reassess, having started an opioid, you would reassess to see how she was going.
Thank you. So you've sort of briefly touched on titrating, and that the role of the way we do it in Australia might change given, the potential limited availability of, morphine mixture, which is what we traditionally use. So I'd be interested to know, because you're probably thinking about how you're going to manage that. And also, what would your stopping rule? Would you have a stopping rule for?
Yeah, that's a really great question too, because as the anti-cancer treatments kick in, the pain can reduce. And so there are times in my clinic I spend a lot more time reducing and stopping opioids, even for people with ongoing disease, because really you want the minimum analgesia that provides the outcome, the pain relief, the pain level that person is looking for, and the function that they're looking to undertake. So I don't have a stopping rule per se, but I do. My general principle is the minimum opioid that has the result that you want, but with the minimum adverse effects.
So, Tim or Jessica, do you have a stopping rule? What do you think about what Melanie's just suggested?
I think it's very patient dependent, and it depends what's happening with their disease and what's happening with their pain. But definitely the patient needs to be booked in for a reassessment to consider what the ongoing requirements for analgesia are.
And from my point of view, I wouldn't be. I think I'd be in these sort of mixed pictures. It's not for me to make that decision. I think it's in liaison with PALCare, who are, I guess it's always broadly played out that the sort of PALCare manage the pharmacological, and then we have a more defined role in whether we come in and do an intervention and then pretty much exit Ken. So I think it's just the best way to avoid too many cooks spoiling the broth.
Good. And as a very experienced and expert palliative care clinician, Melanie's, you're well placed to make that call. And I think it's interesting to hear, because we often think palliative care is about starting drugs and never stopping them. But so it's particularly morphine, good to hear about that. So what would you be thinking about the opioid in any relationship to her family life, her impact on working, driving? She's young, it's a couple of years later, or you're just sort of very focused on getting on top of this acute pain?
Yeah, no, I mean, as I say, it's associated with her goals. In terms of driving, it's when there's acute changes in pain or in opioids that people should not be driving. But when things are stable and there's no adverse effects, so no drowsiness or fogginess, driving is okay. But yes, very much the whole picture of how she's functioning and what happens with the family, how the pain's interfering, how the treatment's exacerbating the pain. For instance, if she was to have radiation for those vertebral mets, whether she had a flare, whether she might need more, but then she might be able to have a titration down.
Yeah. So thank you. And just before we go to take more questions, I just want to make, Tim or Jessica, did you have any, or Michael, did you have anything else you want to add from a management perspective for Mrs. A at this stage of her disease? Yeah, Michael's got his hand up. Yep.
Sure. I was just going to touch on the role of the caregiver or support person as part of the patient's treatment focus, especially in terms of assisting with compliance with recommendations and overall support. If a person's got persistent pain, it's pretty likely that the family's witnessed that and it's having an impact on them. So I think having some sort of screening or understanding of the caregiver issues that go along with that would be useful.
Thank you, Michael, for reminding of that, because it is a whole of family situation. And in my experience, families are often the best titrators of opioids in the home setting. So, Tim, Jessica, anything else to add? No? Nod from Jessica. So that, just before we, as I said, go to final questions, Karen, I'm really keen to come to you for final comments. You know, you've heard all of these experts talk about how they're going to manage Mrs. A's pain. Do you have any final messages for the group?
I think just that we are human, and we're not lying when we say we have got pain. You do get GPs that will say that's out of my scope. It's to do with your disease. You go back to your specialist and they can handle it. Specialist's not here. I've come to you for help. So yeah, I think pain management and nerve pain management is poorly taught in the school, in the medical school, in the medical scene, full stop. I think, yeah, a little bit more needs to be done in regards to what drugs can be used for the nerve pain, and that nerve pain does exist and patients aren't lying when they say they've got it.
Yeah, so that's a really powerful reminder and a good way to wrap the case up. So thank you for sharing expertise. Just get you to, yeah, thank you. We're going to go to some questions. So radiation therapy, you know, how useful is it for neuropathic pain? So who wants to take that question? So Melanie might have touched on it a little bit in the second part of Mrs. A's case, but
yes, I mean, it's a really great question, and it depends how much the bone lesion is impinging on a nerve root, and whether in fact the radiotherapy relieves that pressure. We know that radiotherapy is really good for bone mets, but the evidence for radiation and neuropathic pain is not quite as good, except there are cases where it's very effective. For instance, in pancreatic cancer, some directed SBRT, stereotactic body radiotherapy, can be very effective when directed to the pancreatic mass, which is causing an impact on the celiac plexus lesion. So there are specific cases where radiotherapy is really good for neuropathic pain.
So what would your advice be to clinicians in the audience? Like, reach out to you?
Well, for Mrs. A, she's got two potentially responsive lesions for radiotherapy, that both the lung lesion and the vertebral lesions. So I would definitely be referring to a radiation oncologist for consideration of radiotherapy, as long as it was consistent with her other goals of care.
Yeah, great. Thank you for that. So we have another question. It's quite a long question, but it's so what's the evidence around protective factors in patients that having existing psychological coping strategies? You know, people have used meditation or I don't know, I'm going to add yoga or mindfulness in place prior to major surgeries. Do they reduce the severity and impact of neuropathic pain in the future? But sort of thinking about the coping strategies that people have, and it sounds like in a pre-morbid sense, you know, what we bring to our illness that we've used in the past. So is there much evidence around that? Tim, you've got
There isn't at the moment, and there should be. I guess it's taken a long time to recognise what the risk factors are for developing persistent post-surgical pain, and there's not as much study to show what people are doing themselves beforehand, and does that lead to an improved outcome compared to someone who isn't doing that. My feeling is that it does help, that we should be encouraging people to do all of those things from the time of even surgical consideration of a surgery. We should be pushing the surgeons to refer to pain and palliative care, whoever is just one of us aligned people to get all of those different strategies going, because the studies are clear that anxiety, mood disturbance, depression, catastrophizing, all of those things directly impact someone's chance of getting persistent post-surgical pain. So whatever we can do to prevent it, whatever it is, let's do it. So, because persistent post-surgical pain is as we all know, is such a troublesome condition for so many, that try and tick the box of absolutely everything beforehand is essential.
Thank you. So I hope that has answered your questions. Jessica.
Oh, and I just wanted to add, there's a growing evidence base for prehabilitation, and so this model could really neatly fit within that.
Do you want to talk a little bit more about, and then I'll come to Melanie, prehabilitation?
Yes, so, well, it's like rehabilitation, but pre-surgery. And it's where the patient goes to, say, a course of, like, for example, 3 sessions with a physiotherapist and a social worker, for example, or a physiotherapist and a nurse, or the exact content varies. I think the evidence base for what it should comprise is still growing, but they look at both physical and psychological and social readiness for surgery.
Great, thank you. And Melanie, you wanted to say something?
Yes, as a related point, there's an increasing evidence base around post-surgical pain management with various non-pharmacological strategies as implemented by the acute pain team.
So we've got a few more minutes for questions. If there are any outstanding questions from the audience, I think we've answered. There are no open questions at the moment. So if there are no, I'll give everybody out there in the virtual world, if you've got some final questions for this fabulous panel before I thank them, now is your chance. Otherwise, I will take the opportunity to thank you all for contributing. It's been a wonderful conversation. I think what is really highlighted to me is just the huge complexity, and actually how really very nuanced it is for every individual patient, and why it's so critical that we actually take a person-centered approach. And there are so many really key lessons to remember from this. And I think, we'll start with Karen by saying, being reminded, if we do need to be reminded, and I think sometimes we do, pain is actually what the person says it is. I'm constantly reminded that every day in our cancer centres and GP practices and hospitals across Australia, there are people presenting and seeing incredibly skilled doctors and nurses, but nobody actually really asks them about their pain. And they often, and we found that, didn't we, Melanie, in a big stop pain trial that we did, they often don't want to interrupt, or they feel that we're also time poor. So I think it's really beholden upon all of us. Just ask the patient, have you got pain? It's an easy question. Then do an NRS. Then actually, I love PQRST as a busy nurse, out in the community. It's really easy to always remember. You've always got your assessment. You don't have to dive for a piece of paper, but it was great, Melanie, you presenting the DN4 questionnaire and actually also presenting how the LANS is also available, particularly if we're thinking people have got neuropathic pain, and really gets to that holistic assessment, which Michael spoke a lot about tonight, in getting us to think about not only screening and assessing people in a holistic way, and thinking not only of the person but also their family and the impact the pain has on them from a very holistic perspective. And then it was really wonderful to get an update on the new drugs, the evolving evidence, some of the old drugs that are still available, that are actually still tried and tested, and their younger, better behaved siblings. I love how you presented that or framed that, Tim. It was great to really also be reminded of all the self-management strategies and the great resources that are available in terms of the self-management diary, which patients actually really love. And I think it actually really provides our patients with agency to really take charge in what can often feel like a really uncontrollable situation. Also like to be reminded that we really need to ask the patient about what their aim is, and 0 may not be what they're aiming for. And I think, that's a really realistic thing when many of our patients have had pain for such a long time. Tim, I love the fact that you actually said you're constantly thinking of the next step, the next frontier, because often I think we're often just thinking, oh, we'll do this and that will be solved. So that was a really salient reminder to me, all about the strategy from an intervention perspective. And I guess I'm sort of leaving today's presentation being, pain is actually so complex. It's actually a whole of team effort. We really need everybody's expertise, and it's actually everybody's responsibility. So delighted that you could join us tonight in what I think has actually been a really important and valuable conversation. I hope that you've been able to take some tips from these great clinicians and consumer about how you can actually integrate it into practice. So I'd really like to thank the panel. I'm going to give you a virtual clap, as I'm sure everybody is online. But before I end, I would like to share a couple of things. The team would really appreciate if you took the time to, not the panel, or you're welcome to provide feedback, but the participants, a 4-minute webinar feedback survey, which we'll post. Liam's probably popped it in the chat section now, because it actually really helps us and the team to think about how we improve this. So as I said, Liam will send that. And if you missed it tonight, we'll send you a post-event email out tomorrow, which will include the webinar feedback survey link. And most importantly, further reading and resources, because every presenter today actually really provided some great tips. Hopefully we've captured them in that resource. There's lots of really great resources out there. Really, people have spent a lot of time trying to make it easy for busy clinicians to be able to provide, the pain advice that our patients desperately need. And in addition to having such a fabulous panel, I just really wanted to take the time to thank the collaborators of this great initiative, the Australian Cancer Survivorship Centre, Cancer Council Victoria, Cancer Nurses Society of Australia, and the Clinical Oncology Society of Australia. So thank you for joining us, and have a lovely night. So good night.